Welcome to the deep dive. Today we're jumping into, well, a really complex area, feeding and eating disorders of infancy and early childhood. We'll be drawing from a key chapter in psychiatric literature to guide you through it.
Yeah, and what's really striking is how much this field emphasizes the feeding relationship. It's not just about calories in, it's about that whole back and forth between the caregiver and the child. The cues, the responses.
It makes sense. And the sheer scale of this.
Yeah,
Wow. Our source suggests maybe 25% to 35% of infants and young children face some kind of feeding or eating issue. That's huge.
it really is. And when these problems get severe, they lead to a lot of doctor visits. That's why having a clear way to classify them is so vital. The field has moved on from older, kind of restrictive criteria
Towards what?
towards avoidant restrictive food intake disorder,
Well,
or ARFID. This was brought in with DSM-5, and it's important because it works across all ages. It acknowledges that these kinds of difficulties aren't just an adolescent thing. They can start much, much earlier.
okay. ARFID. Let's unpack that. How is it different, say, from anorexia nervosa? Both involve restriction, right?
That's a great question. The absolute key difference is why the restriction is happening. With ARFID, there's no preoccupation with body weight or shape, no drive for thinness like you see in anorexia. Instead, the restriction in ARFID stems from things like sensory issues with the food, maybe a fear of choking or vomiting after a bad experience, or sometimes just a profound lack of interest in eating.
So if it's not about body image,
Mm.
how do clinicians draw the line between a child who's just, a picky eater
Yeah.
and one who actually has ARHID?
Right. The diagnosis really only kicks in when that avoidance or restriction leads to significant problems. There are basically four main areas the framework looks at.
Which are?
One, significant weight loss, or for kids, failing to gain weight as expected, what's sometimes called faltering growth. Two, a significant nutritional deficiency. Three, dependence on tube feeding or oral supplements to get enough nutrition. And four, the eating problem markedly interferes with their psychosocial functioning, like they can't eat with family or go to birthday parties.
That makes sense. It has to cause real harm. So where does that older term, failure to thrive, or FTT, fit into this picture? I feel like I've heard that a lot.
Yeah, FTT has caused a lot of confusion historically. The textbook is pretty clear on this. FTT isn't a diagnosis itself, it's just a description. It means the child isn't gaining weight adequately according to growth charts.
So it's a symptom.
Exactly.
Shooting.
Think of it as a symptom. Not every child with FTT has a primary feeding disorder. There could be other medical reasons. And crucially, some kids with significant feeding disorders, like severe sensory aversions, might actually manage to maintain their weight but still have major nutritional gaps or social problems. FTT just describes the outcome, not the why.
Got it. So if FTT is just a symptom, then a child showing poor growth needs a proper assessment to figure out if it's ARFID, and if so, which type.
Precisely. You need to understand the underlying process, and that's where breaking ARFID down into subtypes is helpful. The chapter discusses three main ones, largely based on the cause. Should we dive into the first one?
Let's do it. The first one, infantile anorexia, IAIA. This sounds like it's rooted in conflict.
That's a good way to put it. It often shows up between, say, 9 and 18 months. This is that stage where toddlers are exploring everything, learning to walk, starting to assert their independence.
And food becomes a battleground.
Kind of. The child is often described as active, curious, playful, interested in absolutely everything except eating. They might have a poor appetite, resist the high chair, turn away from food.
Okay.
And this resistance then triggers anxiety in the parent, understandably, about the child's weight. So the parent starts trying harder, coaxing, distracting, maybe even forcing.
Which just makes it worse.
Exactly. It creates this really difficult, maladaptive interaction. The more the parent pushes, the more the child resists. They get trapped in this cycle.
Is it just about control for the child, or is there something else going on?
Research suggests there's often a physiological piece, too. These toddlers might have higher physiological arousal. They're so tuned into the world around them, they find it hard to sort of settle down and notice their own internal hunger cues. It's like a difficult temperament meeting parental anxiety.
You mentioned longitudinal studies earlier. What happens down the line if this isn't addressed?
Well, the findings are quite concerning. One major Italian study followed these kids up. It found that around 70% of children diagnosed with IA still had eating problems at age 11.
Wow, 70%.
Yeah. And often they also showed higher rates of anxiety and aggressive behaviors. Interestingly, there seemed to be a difference based on sex. The girls with IA and their mothers showed more eating pathology and related issues by age 11 compared to the boys.
That really highlights the need for effective treatment. The chapter mentions a transactional model, focusing on the interaction.
Yes, the treatment aims to break that negative cycle and help the infant reconnect with their internal hunger and satiety signals. It usually involves some key behavioral steps for the parent.
Like what?
Three main things, typically. First, establishing a very regular feeding schedule, meals or snacks offered only every 3 to 4 hours, with just water in between. No grazing.
Okay, structure.
Second, during meals, absolutely no distractions, no TV, no games, no coaxing. Encourage self-feeding as much as possible and don't comment on how much they eat. The focus shifts away from intake volume.
Right.
And third, using consistent consequences, like a brief timeout, for inappropriate behaviors like throwing food. The idea is the parent controls the when and where of eating, but the child controls whether and how much they eat within that structure.
That sounds very structured. Is there a risk, though, that being too rigid with timing could undermine the goal of getting the child to listen to their own hunger?
That's the tricky balance a therapist helps the family find. Initially, that structure might be essential just to break the powerful conflict cycle and let those biological hunger cues actually be felt again. Once things calm down, the approach can become more flexible, focusing on responsive feeding within those mealtime boundaries.
Okay, that makes sense. So we've talked about conflict. Let's shift gears to the next ARFID subtype, which seems less about interaction and more about the food itself. Sensory food aversions, SFA.
Right. This is when a child consistently refuses certain foods specifically because of how they look, smell, taste, feel, or even their temperature.
So texture issues, for example.
Exactly. Or maybe they refuse all vegetables or all meats or anything mushy. The refusal is based on the sensory properties, not fear or lack of interest in general.
And when does this become a clinical issue rather than just being picky?
Again, it comes down to those 4 criteria we mentioned. The diagnosis is made only if the selectivity leads to, say, nutritional deficiencies, maybe delays in developing oral motor skills needed for speech, or if it really messes up their social life, like they can't go to school or parties because there's nothing they'll eat.
Interesting. Is there a biological basis for this?
There seems to be. Research points towards genetics. You might have heard of super tasters, people who literally have more taste buds and experience tastes, especially bitterness, much more intensely.
There can also be links to things like obsessive-compulsive traits or anxiety. And, like with IA, parental behavior matters. Trying to force or bribe a child to eat something they find genuinely disgusting usually backfires and makes the aversion stronger.
So what does work for SFA?
The main strategy is repeated, neutral exposure. It might take more than 10, maybe even 15 or 20 times of offering a tiny bit of the food without pressure before a child even tries it.
Wow, that takes patience.
It really does. And modeling is key. Parents eating and enjoying the food themselves without directly offering it to the child can sometimes be more effective than any coaxing. Now, if the child has a really severe reaction, like gagging or vomiting just from the sight or smell, the advice is often to just back off that specific food for a while.
Okay. That brings us to the third main subtype, which sounds quite different again. Post-traumatic feeding disorder, PTFD. The name suggests fear is central here. Absolutely. Fear is the driving force. What's characteristic of PTFD is the sudden onset of food refusal, almost always right after some kind of scary or painful event involving the mouth, throat, or digestive system.
Like what kind of event?
It could be choking on food, a severe bout of vomiting, maybe a traumatic medical procedure like being intubated, or having a feeding tube placed forcefully. Even aggressive force feeding itself can trigger it.
And how does that fear show up?
The child refuses to eat based on that fear. It might be a total refusal of all food, or it could be specific. Maybe they refuse only the bottle if that was associated with the trauma, or only solid foods if they choked. They might cry or panic just seeing the high chair or the bottle.
That sounds incredibly distressing.
It is. In severe cases, they might hold food in their mouth, refusing to swallow, sometimes called food packing. This puts them at immediate risk of dehydration and malnutrition. It's often an acute situation.
So treatment needs to be pretty intensive, I imagine.
Definitely. Because of the potential medical danger, a multidisciplinary team is essential: pediatrician, nutritionist, psychologist, or psychiatrist. Often, the child needs nutrition support first, like an NG tube or G tube, just to get stable.
And the psychological part.
The core psychiatric treatment is desensitization. It's about carefully gradually re-exposing the child to the feared food or feeding situation in a way that reduces the anxiety, making it safe again. Encouraging self-feeding can also be really helpful here, as it gives the child a sense of control back, which combats that anticipatory fear. And of course, addressing the parent's own anxiety about the trauma is critical too.
Okay, so those are the three main ARFID subtypes: conflict-based,
Yeah.
sensory-based, SFA, and fear-based, PTFD. But the chapter covers a few other related diagnoses too, right? Starting with one focused on the caregiver relationship.
Yes, the feeding disorder of caregiver-infant reciprocity. This used to be linked to older terms like maternal deprivation or non-organic failure to thrive. It typically starts earlier, between 2 and 8 months.
What are the key signs?
The defining feature is a real lack of positive back and forth during feeding, and just generally. The infant doesn't show age-appropriate social responses. They might not smile, not make eye contact, not reach out in anticipation when the caregiver approaches. There's a lack of mutual engagement.
And there's a specific way this is often diagnosed.
Yes, the textbook highlights a classic sign. The infant starts to improve, engage more, and gain weight relatively quickly when admitted to the hospital and cared for by a different, consistently nurturing person, like a nurse.
Wow.
That points directly to the relationship as the primary problem. It's often linked to significant issues in the caregiver, like severe depression, substance abuse, or overwhelming stress. Treatment usually requires hospitalization for the infant initially, and intensive support, often involving social services, for the caregiver and the relationship.
That's heavy stuff. Okay, next is the feeding disorder of state regulation. What does state regulation mean here?
This is about the infant's ability to get into and stay in the right state for feeding, calm but alert. These babies, usually starting right from the postnatal period, struggle with this. They might be extremely irritable, crying constantly and unable to settle enough to feed effectively.
Or the opposite.
Or the opposite. They might be excessively sleepy, drowsy, difficult to wake up, and unable to stay awake long enough to get a full feeding.
And this can happen on its own.
It can, but it also frequently occurs alongside other issues, especially prematurity or underlying medical conditions affecting the heart or lungs, for instance. Treatment has to be really tailored to the individual baby.
How so?
Well, for a very irritable baby, the goal might be reducing stimulation swaddling tightly, a quiet, dim environment. For a sleepy baby, gentle handling, maybe some massage before feeding, might help increase alertness. Sometimes, if they just can't take enough by mouth, temporary NG tube feeding might be needed to ensure they get adequate nutrition while working on their regulation.
Makes sense. Okay, two more distinct disorders mentioned: rumination and pica. Let's start with rumination disorder. What exactly is happening there?
Rumination is, well, it's quite specific. It involves the repeated regurgitation of food. The food comes back up from the stomach into the mouth, usually starting an hour or two after eating. Then the child might rechew it and either swallow it again or spit it out.
And it's often voluntary.
That's the key aspect. It often seems volitional, maybe initiated by the child putting fingers in their mouth or making certain tongue movements. It's different from just passive reflux or vomiting.
Why would a child do this?
It's often thought of as a learned behavior, maybe for self-soothing or self-stimulation. You sometimes see it more in infants who aren't getting a lot of positive interaction or stimulation from their environment. It might provide some kind of internal sensation or tension release.
But it sounds dangerous.
It can be very dangerous. Serious complications include dehydration, electrolyte imbalances, malnutrition, dental erosion. Historically, before effective treatments were developed, mortality rates were reported to be as high as 25%.
Goodness. How is it treated?
Treatment needs to be individualized. It often involves a combination of approaches, maybe psychodynamic therapy focused on improving the parent-infant relationship and providing more stimulation, and also behavioral techniques like providing differential reinforcement for not ruminating, or sometimes using mild aversive taste stimuli like a drop of lemon juice on the tongue when the behavior starts.
Okay. And finally, pica. This is eating non-food items, right?
Exactly. Pica is the persistent eating of non-nutritive, non-food substances, things like dirt, clay, paint chips, plaster, hair, pebbles, insects. The key is that it has to be persistent and inappropriate for the child's developmental level.
So a baby putting everything in their mouth isn't pica.
Right. Mouthing objects is totally normal for infants and young toddlers. That's why the DSM-5 suggests a minimum age of 2 years for a pica diagnosis, usually after that normal mouthing stage should have passed.
What are the risks?
The risks are pretty obvious: and serious lead poisoning from paint chips, parasitic infections from dirt, Nutritional deficiencies like iron or zinc deficiency, which might also sometimes contribute to the pica. Intestinal blockages.
So how do you approach treatment?
It requires a really comprehensive assessment. First, rule out and treat any nutritional deficiencies. Then, environmental safety is key child-proofing the home, removing access to the non-food items. Strengthening the parent-child relationship and providing adequate stimulation is important. And behavioral techniques can be used, like teaching the child to discriminate between edible and inedible items, or reinforcing them for bringing in edible items to an adult instead of eating them.
Wow, okay. So we've covered a lot of ground here. From ARFID and its subtypes, infantile anorexia, sensory food aversions, post-traumatic feeding disorder, through to issues rooted in reciprocity, state regulation, and specific behaviors like rumination and pica.
Yeah, it's a broad spectrum.
And I think the big takeaway for you, the listener, is just how complex these early feeding issues can be. It's not just about weight gain. The underlying cause, whether it's conflict, sensory issues, fear, relationship problems, or state regulation, is critical for figuring out the right treatment.
Absolutely. It underscores the need for careful assessment and an individualized approach. And maybe one final thought, tying back to that longitudinal data on infantile anorexia.
The finding about girls.
Yes. The fact that girls with that IAARID subtype showed increased eating pathology and related issues by age 11 really poses a critical question for the future, one the field is actively looking at. How do these early non-body image focused restrictive patterns, especially in girls, evolve as they move into adolescence? Could they, in some cases, be an early pathway towards developing full-blown anorexia nervosa during that high-risk period?
That's a really powerful question to consider. It highlights the potential long-term echoes of these early experiences.
Yeah, it certainly does.
Well, thank you for joining us on this deep dive into the complex world of early childhood feeding disorders. We hope this breakdown of the key concepts from the source material has been helpful. Go forth and be well informed.